Welcome to today's webinar on hypertrophic cardiomyopathy, hosted by CardioServ, with guest speakers Dr. Ronald Wharton and Margaret Kurnides. My name is Katie Hill, and I will be your facilitator today. Before we begin, we're excited to share a feature available with all of our webinars. Whether you're watching live or on demand at any time in the future, the chat box will remain open. We regularly review questions and comments and will either respond directly or incorporate them into future educational sessions. We encourage you to engage throughout the presentation. And now, I would like to introduce Judith Buckland, founder of CardioServ.
Thanks, Katie. Thank you all for joining us tonight as we review the best practices for echo in hypertrophic cardiomyopathy. My name is Judith Buckland. I am the founder and president of CardioServ. We have dedicated the past 2 decades to improving the quality of diagnostic imaging in the ultrasound space. And our mission is inspiring excellence in imaging. We want to inspire you to be your best, do your best. And one way we're doing that is by jumping in front of the potential HCM standards that IAC is getting ready to drop. So to be fully clear, the Intersocietal Accreditation Commission announced last year that they were going to add HCM as one of the testing areas for adult echo. So currently, when you're accredited with IAC in adult echo, you can add on stress echo, TEE, well, now you will be able to add on HCM. These standards are not finalized and is awaiting the board of directors at IAC to formally announce the final set of standards that will be used moving forward. But because we are eager beavers, we wanted to get ahead of the accreditation standards. So we took the standards that were dropped and made open for public comment. We took all of those and we added them to our peer review. We know that not all of them may stay. We know some of them may be changed, but it was a good starting point in regards to how do we assess the quality of HCM echo. Now remember, this is not an HCM center of excellence. This is an accreditation for facilities that may not even see that many HCM on a regular basis. But by seeking HCM accreditation, it puts the spotlight on what are we doing? How are we doing it? Are we following the best practices that Center of Excellences are following? So I thought, what a great opportunity to put together a panel to discuss best practices of HCM in echo with a physician and a sonographer to get both perspectives on best practices of echo. So I'd like to introduce you to our speakers, Dr. Ronald Wharton and Margaret. I apologize. We have been saying your name wrong, but it's Margaret Kurnides. Please go ahead and introduce yourself and tell us a little bit about your background in HCM. Dr. Wharton.
Okay, thank you for having me. I am a non-invasive cardiologist. I've been doing echo my entire career. And since 2019, when I moved to my current location at North Shore University Hospital in Manhasset, New York, I've been running the hypertrophic cardiomyopathy program at that institution, which I founded. I have a lot of experience seeing patients with HCM, and my facility has been fortunate enough to participate in 4 clinical trials and 2 clinical registries in the HCM space. And it's never been a more exciting time to be doing HCM because of all of the new therapeutics that are emerging.
Awesome. Okay, Margaret, I'm going to let you say your name correctly and introduce yourself.
Thank you for having me. I'm Margaret Kurnides, and I am a sonographer, advanced cardiac sonographer, and I have been performing echo since 1997. And I have been blessed to have worked in a center of excellence with Dr. Matthew Martinez in Morristown, New Jersey. And it's just through working with him and all the experience of our patients and in our center, we have really spent so much time on goal-directed Valsalva and just feel we need to share the wealth with this. And it has been so amazing in getting our patients in order and where they need to be, diagnosing them properly. So that's where I am. And most recently, I am now in a Mayo Clinic and hoping to do the same here.
Awesome. Thank you both. So of course, IAC always follows ASC's guidelines. I'm going to pull up the ASC poster, which is a free resource when you go on ASC's website. And we're going to just go through like the main money shots of HCM. And as we go through the studies, both of you will jump in and share some experience and tips and techniques. Okay, so let me share my screen. So this is ASC's website. If you go under their resources, under hypertrophic cardiomyopathy, okay, this is their poster that has the main items of a echo for a patient with hypertrophic cardiomyopathy. And we're going to just look at the peristernal views. I'm going to pull up a study and we're going to look at the main requirements in peristernal, obviously being the 2D measurements of the IVS and posterior wall in both long and short axis, and then M mode, and paying attention to the color of the MR. I was saying to Dr. Wharton earlier, Margaret, that I think you guys see it every day so much that you don't realize that some sonographers have never seen SAM on M mode, or they think they have never seen it. So there's some things that are so basic and common to you, but I would like to take the time to actually point that out for those that don't have any experience at all. So if you put the probe down and this is what you're seeing, what are you thinking, Margaret? Talk me through what you're seeing and some tips and techniques for best practices.
I think from a sonographer perspective, when we put the probe down and we see an image like this, we're automatically curious of whether it is HCM, amyloid, like what do we have here? And so we need to start right away in thinking, how can we tease this out so the physicians are well aware of what we have here? So it's looking at the wall thickness, making sure that we measure appropriately in our 2D, that we do not include the RV apparatus or anything of the RV in that measurement, so it's accurate. We include a mitral M mode so that we can definitely classify if there is systolic anterior motion of the mitral valve leaflet.
So let's pause for that. Basically, it's just looking for this systolic.
This little bump, right, the systolic anterior motion. So you see that little bump there after the normal mitral valve tracing that you would see, and then you see just this little hump, and that's the systolic anterior motion of the mitral valve leaflet. So this is important. So when you see those thick walls, you think that you have SAM, you should definitely do mitral valve M mode. Also, you can put on color and do a side-by-side view and increase your loops and have the patient perform a Valsalva so that you can see if we increase the turbulence and if we increase the severity of the SAM.
So you're having them Valsalva already in the peristernal views?
We do.
What do you do, Dr. Wharton?
We typically don't, because the Valsalva to me is most useful when I'm looking at velocity. The turbulence and the color obviously will become more turbulent when you Valsalva, but that's a qualitative assessment, not a quantitative assessment. And the quantitative assessment is what's going to correlate with the physiology, and it's also the quantitative assessment that's going to serve as your basis for therapeutics. So looking at this image, obviously it's a thick LV with a small cavity. The SAM is very apparent. The other thing that you'll also notice is that the left atrium is big. And so you already realize that this patient has elevated filling pressures, either from the diastolic abnormalities that correlate with HCM and or the varying degrees of mitral regurgitation, which may or may not be present. And I think, by the way, Judith, in your slides there, you may have passed by an aortic valve M mode.
Let's see.
So,
okay.
Right. So if you go there, you will notice that there is a little notch in the aortic flow during systole. And a systolic notch in the aortic M mode is also consistent with obstructive HCM. Where the notch occurs is variable depending on the degree of obstruction. But the point is that when the obstruction is sufficiently egregious, the flow through the LVOT has diminished enough that the aortic valve leaflet is no longer have the requisite flow to remain parallel. So they actually start closing in the middle of systole.
Mhm.
So the aortic valve notch in systole is as much of an M-mode finding in HCM as the more taught and more recognized mitral M-mode.
Okay. So do you always measure short axis?
We will measure with a free caliper in short axis, and again, making sure that we are not including any of the RV in our measurement to make it larger, but we do not use the measurement package. We only use a free caliper here to measure the thickness of the walls, and it can be anywhere in the LV. It doesn't have to only be that basal septal wall.
And if the thickest segment is not the number that goes into the measurement package, if a facility was to not get that into the final report, that's problematic.
Right. So the physician should have that in the report through the information that we provide and the location of the thickness and the pattern of hypertrophy as well.
So we do the exact same thing.
Okay, so we're going to switch over to Dr. Wharton's case studies. So I'm going to stop sharing.
Okay. Do you see my slides?
I do.
Yes.
Okay. All right. So we're talking about obstructive hypertrophic cardiomyopathy. And this is what it might look like when you put color in your parasternal long axis. And I show this because not all patients are equally sonogenic, which is sort of the same thing as photogenic for an ultrasound. But even if your 2D images are not that great, if you see a splay of turbulence like this, where you have a turbulent flow going into the aorta, and turbulent flow also going to the left atrium, and they're roughly something about 30 or 40 degrees apart. Nothing else does this besides systolic arterial motion of the mitral valve and dynamic LVOT obstruction. When you see an image like this, you have a diagnosis. It's obstructive HCM. And since echo started with M-mode before it became far more complicated, here's just a classic example of the mitral valve M-mode. Again, anytime you look at an M-mode, time it to your electrocardiogram so we know where systole is. And there's also a B bump here, by the way. See that there's an elevated end diastolic pressure here, the AC shoulder in the mitral M mode. And then systole ensues, and the mitral valve is supposed to stay down here, and yet it's coming right up here and hitting up against the septum. And you can imagine if you're a red blood cell and you're somewhere over here in diastole, and your goal is to get this way, well, obviously you're going to hit an obstruction, and that causes the symptoms of obstructive HCM. In fact, you can even see this finding as well in the aortic valve M mode. When systole ensues in a patient who has dynamic LVOT obstruction, there reaches a point where the flow through the LVOT diminishes so much that the aortic valve actually starts to close a little bit. And where this notch is obviously depends on the degree of obstruction from patient to patient. As an aside, it's not terribly surprising that the left atrium is enlarged because the hallmark of hypertrophic cardiomyopathy is diastolic dysfunction. And where you have stiff ventricles, you frequently have large left atria as well. And I should mention, just because I think it's very important, especially because of the way this correlates with the therapeutics, why does SAM happen? SAM happens because you have a perfect storm. Number one, you have a thickened ventricle, but especially so in the septum. Number two, you have an overpowered ventricle. I think any of you who have scanned HCM, you typically report an ejection fraction of 70%, 75%, 80%, or something like that with a small cavity. And finally, you have a mitral valve that is both redundant, has too much slack on it, and often somewhat anteriorly and apically displaced. When you have this perfect storm, you set up a situation where you have changed the flow patterns in the left ventricle such that the mitral valve is approached from below, and the mitral valve leaflets are pushed in the way of the aortic valve. In fact, SAM starts at end diastole with atrial systole. The LVOT velocity is not even yet 1 meter per second. So the mechanism of SAM is push, it is not pull. Doppler waveforms. So on the left of this panel are two continuous wave Dopplers. These are Doppler envelopes that peak in mid-systole. And this is what happens when you have a fixed obstruction. Aortic stenosis being extremely common, and a subaortic membrane, a cause of turbulence that you might see in the LVOT, and you might say, wow, there's turbulence in the LVOT, maybe this is HCM, but this is not because it peaks in mid-systole. If you look at the waveform over on the right, you see a classic dagger shape of systolic anterior motion causing dynamic LVOT obstruction. Why is this dagger shaped? Because as systole ensues, the LVOT gets smaller and smaller. And as the LVOT gets smaller and smaller, the velocity gets higher and higher. So this is a late peaking jet. which correlates with dynamic LVOT obstruction. You can also notice that this jet ends right over here, and the mitral inflow starts a little bit later. That's one tip that tells you that this is LVOT flow and not MR flow, because MR would continue through isovolemic relaxation. HCM, being an ejection flow, ends at the ejection period, and there is a gap between the end of ejection and the beginning of diastole, that being the isovolemic relaxation period. Okay. This is a continuous Doppler of a patient with LVOT obstruction in the apical 5-chamber view. And this is about as high as it gets. HCM velocities in extreme cases I've seen get up to about 6.5 or a little more, but that's pretty much the limit of what you can put into the LVOT and going into the aorta. It doesn't get much higher than that. Please note that you do not need to trace this, okay? Tracing envelopes helps when you're trying to determine flow by multiplying cross-sectional area by a VTI. But don't forget, in HCM, the cross-sectional area of the LVOT is changing every little millisecond during this envelope, right? Since the cross-sectional area is constantly changing, you can't determine the flow through it by doing a tracing. So you don't need to trace it. Don't waste your time. All you need here is a peak velocity right there, and that's going to tell you your peak gradient. Compare that with the mitral regurgitation in this same patient, and you'll notice that the MR velocity is a little fatter because mitral regurgitation is going to continue through the isovolemic relaxation period, but also the MR velocity is higher. The MR velocity here in this patient is 8.1. And by the way, if you see any MR velocity that gets into the 7 or 8 range, you've also made a diagnosis of obstructive HCM, because no other clinical condition generates LV pressures that are that high. Remember, in any given patient, the LVOT velocity has to be lower than the MR velocity. Simple reason, there's only one LV that's generating both, and the aortic pressure is always higher than the left atrial pressure. Therefore, the gradient between the LV and the LA is always higher than the gradient between the LV and the aorta. So in this patient, you have an LVOT velocity that's peaking somewhere probably around 6.6 meters per second, and here you have an MR velocity that's peaking at 8.1. Notice that the peak LV pressure in this patient is easily over 280 millimeters of mercury if you just take 4V squared and add what you might expect the left atrial pressure to be. So HCM has the potential to generate enormous LV pressures, and the only way the LV can tolerate those is obviously by being extremely thick, which of course they are. Remember, unlike aortic stenosis, a LVOT obstruction is dynamic, which means it can change very rapidly just by changing loading conditions or position and the like. So for instance, here's a patient with an LVOT velocity here of about 2.4. This would not be considered significant, but after a Valsalva maneuver here, you can see the LVOT velocity is up to about 3.2, right? And again, what makes the LVOT velocity go higher? Anything that makes the LV smaller or anything that makes the LV squeeze harder. So Valsalva, by temporarily decreasing preload, makes the LV smaller, hyperdynamic, and you get this increase in your LVOT velocity. You can also get this after exercise, and this is the same patient with a resting gradient of 33 at a heart rate of 50. This is post-exercise, and obviously the patients had a little time to recover because their heart rate's only 77, but they still have the inotropic effects of exercise. And you'll notice that on this scale here, which has had to be increased to accommodate the velocity, you have an LVOT velocity now of 5.3, which corresponds to a peak LVOT gradient of 112 millimeters of mercury. These gradients can vary very greatly by little things, just as sitting up quickly, standing up quickly, bending down, or depending on what it is you're doing. This is a patient here where you can see there's some mitral septal contact at rest in the apical 3, and you can see that there's some turbulence here in the LVOT when we add color. And again, this was their resting gradient, and you can see the resting gradient is not high at all. The velocity here is only about 2, so that's a gradient of roughly 16. They did do a good Valsalva, and I didn't have a treadmill available at the time to exercise. And so what we did was that we actually did jumping jacks. And I chose jumping jacks simply because we can exercise the patients without disconnecting them from the echo machine. So as soon as they're done exercising, we can start scanning them immediately without wasting time putting leads back on. And you'll notice the scale here has been changed, and the gradient here is now over 4 meters per second. So you've got a gradient here of at least 70 millimeters of mercury. I want to show you this for a couple of reasons. This is a patient who has obstructive HCM, and we're in an apical 5-chamber view. And you'll notice that all of these gradients here are pretty boring, right? These velocities are not high, except for this one. Remember that this happened here after a PVC. Okay, this is a well-defined characteristic of HCM, which is that after a PVC, you have a pause. And during that pause, you have more time for the myocardial cells to accumulate calcium, and the subsequent beat comes in with a greater force than the other beats. And so you get this gradient here. This is actually referred to as the Braunwald phenomena because they first published it back in the early 1960s. The other thing to remember is that if you're writing a report on these patients, sonographers are very well trained to look for the highest velocity they can find. Remember, always time it to the electrocardiogram. If one of them looks different from the others, make sure that there isn't something different on the electrocardiogram because this is a post-PVC. You always want to make sure that what you're measuring is at the regular hour interval. Now, I show you this just as a curiosity so that people know that it exists. This is a patient who has mitral septal contact from the systolic anterior motion of the posterior leaflet. Do you notice, Judith, how the anterior mitral leaflet is coming over here? And it's the posterior leaflet's actually coming and making the mitral septal contact. These patients can have the same symptoms. The other thing about them is that the mitral septal contact tends to be a little more apically displaced as a rule. The MR tends to be a little milder. And I just mentioned to people that it exists and that the reason I never published it is because Barry Marin did 40 years ago.
Have you ever seen that, Margaret?
Oh, yes. Yeah.
Oh, wow.
I have a handful of those.
Then it was worth showing.
Okay, a couple of caveats. You may recall that we said one of the ingredients that's necessary for dynamic LVOT obstruction is a mitral valve that has too much slack on it, that's too redundant. Well, that's also the case in patients who have mitral valve prolapse, and occasionally you may see the same two conditions in the same patient. The tip-off will be that the vector of the mitral regurgitation may not be what you're used to. Don't forget, when mitral regurgitation is purely from SAM, the MR jet tends to go posterolaterally. And if you have MR vectors that are different, then you may have to think that the patient has a second condition like prolapse. And it can also be much more challenging to tease out on your spectral Doppler because the jets may be much closer than you're used to. So here's an example. This is a patient who clearly has dynamic LVOT obstruction. You can see in the apical long axis on the left, mitral septal contact. And when you look at it with color, you see the turbulence that you would expect in the LVOT, but you also notice that the MR jet is not posterolateral. It's far more anteriorly displaced than you're used to. Now, you can imagine if you're doing continuous Doppler here, this can be very difficult to tease out, right? Because CW is range ambiguous, and it's going to be very difficult to be parallel, to get to the LVOT without catching some of that MR. You're probably going to get both jets in the same frame, and you may have to turn the gain down subsequently to discern one jet from another once you have your spectral Doppler profile. Just remember that these conditions can exist. What we did here is we gave up some velocity just to demonstrate the density of the MR signal. Obviously, the velocity is higher than this because this is an anterior directed jet and our beam is directed a little more posteriorly, but you can see that this is an MR jet with velocity over 6 here. So in reality, it's probably closer to 7 or more because, again, we're not parallel. You can also tell that it's MR because it starts at the beginning of isovolumic contraction and it ends at the end of isovolumic relaxation because you can see as soon as the MR jet ends, the mitral inflow starts right there. And this is what this looked like on 2D. You can't see the SAM here because the SAM is from the other side, from the ventricular side. We're looking here from the left atrium. The aortic valve is on top. So the top is anterior, bottom is posterior. The left side here is lateral and the right side is medial. And what you see here is an MR jet that is directed anterolaterally from prolapse here in the posterior leaflet. So just so you know, these conditions do coexist, and this is a patient who might have to be referred for surgery for definitive treatment. The other condition I want you to be aware of is the fact that SAM can frequently coexist with valvular aortic stenosis. Aortic stenosis creates thick left ventricles. Some patients with thick left ventricles may have the recipe for systolic anterior motion of the mitral valve, either at the same time or after the aortic stenosis is treated with a treatment such as a transcatheter aortic valve replacement. So it's very important to look closely at the mitral valve in patients with aortic stenosis, especially if you either see SAM or if you see chordal SAM, the harbinger of SAM, and you might imagine in your mind's eye what might happen to this ventricle if all of a sudden the afterload of the aortic stenosis were relieved. Could this patient develop dynamic LVOT obstruction? What we've done in our lab, because we have several of these patients, is we try to scan them, sacrificing a little velocity in the way of not being totally parallel in order to tease out both jets individually. And this is a patient who has these conditions. I think her septal thickness was something in the vicinity of 22 to 24 millimeters. You can see the mitral septal contact here very easily, but you'll also notice that the aortic valve is extremely calcified with reduced excursion of the leaflets. And what we did here is we did continuous wave Doppler of the LVOT, avoiding the aortic valve, diving right into the left atrium. And you can see here this dagger-shaped jet with a gradient of 95 millimeters of mercury. We then went directly into the aorta, avoiding the LVOT in the same patient, and we have this mid-peaking jet at a velocity of 5.3 meters per second. Not a surprise based on the 2D images that I showed you. As an aside, just to give you an idea of the kinds of pressures that this patient can generate, this is the MR velocity. And this is a record for me, and I've been doing this for a couple of years now. The MR velocity in this patient was 8.7 meters per second. That means the gradient between the LV and the LA was 305 millimeters of mercury. And you can imagine the LA mean pressure is at least 25. It's probably more. So what we're saying is the peak LV systolic pressure of this patient is in the vicinity of 330 millimeters of mercury. Only a ventricle with severe concentric hypertrophy would be able to manage to do this. So these conditions can coexist, and it's very important to recognize it if you can find it before the aortic valve stenosis is treated. And certainly if you don't before, it can happen after the patient's aortic valve has been fixed. And once you relieve this fixed obstruction, you can bring out the dynamic obstruction, having solved one problem and created another. A few comments on non-obstructive HCM, the definition of this being a patient who does not have systolic anterior motion of the mitral valve. Patients with non-obstructive HCM can have obstructions to flow, but they're typically mid-cavitary. There are patients who can have mid-cavitary obstruction and SAM. One obstruction doesn't preclude having another one. But when we're referring to patients with non-obstructive HCM, we're talking about patients who meet definition of HCM, but they do not have dynamic LVOT obstruction. This is one such patient here. And this is a patient who has mid-cavitary obstruction over here. And you'll notice that there's a small apical aneurysm. These can be easy to find if you add an ultrasound enhancing agent. Not all of you may have an ultrasound enhancing agent available, especially if you're in an outpatient facility, in which case one other way you can make this diagnosis is by using your continuous wave Doppler. Let me show you what I mean. In the color images here on the left and on the right, I'm showing what this looks like in freeze frame. In early diastole, you'll notice that the mitral valve is open and flow is coming in, but in early diastole, the aneurysm here is also emptying. In fact, these apical aneurysms here, which are formed because of the pressure effects of mid-cavitary obstruction, these apical aneurysms typically only fill during atrial systole. So what does this look like on continuous Doppler? Well, you'll notice that there's this jet here in systole that goes down and comes back up. Its velocity is not particularly high. The signal is fainter in the middle of systole because the flow through this area is diminished because the two walls are literally slamming into each other. But you'll notice that the flow continues well into diastole and doesn't stop until atrial systole. So if you get a continuous Doppler in your apical 4 or your apical 2 chamber view, where you have two confluent flows at the exact same time, but in opposite directions, you've made a diagnosis of mid-cavitary HCM because nothing else really does that, right? You have the flow coming from the apex towards the base at the same time as you have mitral inflow. In fact, this is the exact same patient in the apical 3 where you're also bringing out the MR jet. You'll notice that the MR jet is at a velocity much more consistent with life, right? Because MR typically is at about 5 meters per second, and MR ends when the mitral valve opens, as opposed to this flow from the apex towards the base, which continues in through diastole. The other thing I want you to be aware of is that continuous wave Doppler, because it's range ambiguous, can be very deceiving. And I want to end my presentation with this just to show you how scary this can be. Here's a patient who has very good systolic function. You can see the LV is thickened. There's asymmetric septal hypertrophy here. You don't really see any SAM here, but when you put color on there, you certainly get something that looks like a SAM, right? Because you've got turbulence over here and you have an MR jet that's going posteriorly. And well, maybe I'm not seeing the SAM, but in fact, this patient doesn't have SAM at all. This patient has obstruction closer to the base of the heart, but in fact, there is no turbulence in the LVOT. All the turbulence is up here, and there's not a drop of MR. So it might have looked like SAM in the aparasternal long, but it's in fact a patient with non-obstructive HCM and just turbulent flow over here. The obstruction is not at the aorta mitral curtain, but slightly further apically displaced. And when you Valsalva them, they can have this exact same waveform, right? It looks like a dagger shape. It's at the end of systole. They say, wow, it's SAM, but it's not. So be very careful that when you look at your continuous Doppler, that it correlates with what you see on your 2D and your 2D with color. Finally, ultrasound enhancing agents are a very valuable thing in this condition. This is a patient who has HCM, but not obstructive HCM. And you can see that the distal segments of the LV are very thick. You say, well, this looks like it's over the apex, so there's probably no aneurysm over here, right? It's probably just all apical HCM and nothing beyond that. But in fact, when you put an ultrasound enhancing agent in there, you can see that there is a small aneurysm. This is very, very important to make a diagnosis of. Of course, an MRI will probably see it as well, because these aneurysms are often thought to be the nidus for ventricular arrhythmias, and therefore you might want to have a little more vigilance regarding your ambulatory monitoring for arrhythmias in these patients. So with that, I'm going to hand the presentation back to Ms. Buckland, and thank you for listening.
I wanted to just say that the examples that Dr. Wharton just showed were excellent. And I think that it's from a sonographer perspective, we should be always thinking what the physician is looking for and what we need to provide for the physician, because they're not with us when we're scanning. So all of the great examples of how to move into the different areas of flow to get exactly the information that we need, we just always have to be thinking of how to tease out the gradients, the velocities, and where are we and what are we actually seeing on those Doppler tracing. So that was great. Excellent.
Thank you. Yeah, I always tell our sonographers, use your 2D and your color first to decide how you want to use your spectral Doppler.
Right. Locate it. Yep.
Exactly.
So goal-directed Valsalva, Judith, I think.
Yes.
So really for us, when we decide we're going to do it is right away when we see SAM. So if we do not see SAM, we typically do not use it. But we still incorporate instructed Valsalva, so the traditional Valsalva, and goal-directed Valsalva in each of our exams. And I would say mostly it's coming from us probably doing our research and trying to figure out which is more important and which do we use. Both of them have a place. Goal-directed Valsalva is definitely, I feel, should be the gold standard. I mean, it's easier to do. It disrupts the image less than the instructed Valsalva. But not everybody can do it. A very small percentage of our patients are not able to do goal-directed Valsalva. So I think it's important to use both whenever possible to see where you can get your best data.
What do you use in your lab, Dr. Wharton?
My lab?
Mm-hmm.
So we don't have any of we haven't purchased the necessary paraphernalia, as it were, for a goal-directed Valsalva. So what do we do? If a regular good old-fashioned Valsalva isn't giving us what we think we need, we may stand the patient up, sit the patient up abruptly, or stand the patient up abruptly, and then try to do an apical image, either an apical 3 or an apical 5 while they're standing, before they have a chance to equilibrate. Beyond that, as I showed, we do jumping jacks. In fact, sometimes I'll do it with the patients because it encourages them and the sonographers get a kick out of it. And also, regrettably, with my schedule, that might be the only time I get exercise that day. But the reason I chose jumping jacks is very simple. I can exercise them and at the same time keep them connected to the machine so that when they're done, we don't waste time reconnecting them, during which their heart rate can start to recover. So they do it right at the bedside, and then we get them right back down. We typically ask for 20. So that's what we do, sort of. Certainly if we can get the equipment for goal-directed Valsalva, that's fine. But, I don't make purchasing decisions.
But I saw that you did annotate what kind of maneuver you did, because the one image said jumping jack. So do you all?
That's what we did.
Yeah.
Yeah.
So Margaret, in your labs, do you annotate on the image?
Yes, we annotate exactly what we're doing, and we should be, because otherwise, lucky for the physicians with you, Dr. Wharton, you're present with them, and that's mostly not the case. So then how would any of other physicians know what are they doing here? What is this gradient coming from? So it always should be documented. When you're going back to what Dr. Wharton just said about he doesn't make the decisions in terms of with the supplies, that is something that we have been encouraging many of the sonographers in their labs to get the buy-in from their physicians. Is it something that the physicians are interested in using in diagnosing their patients? And then you really do need the administration involved. You need to, in every facility is so different and everybody's using so many different types of tubing and different filters, or sometimes no filters. So I think it's a matter of the physicians first being on board of whether they feel it's going to make a difference, and then the administration. So your managers, infection prevention is another big one where they should be involved in terms of what they think is necessary for you in terms of providing that part of the test.
So do you want to talk us through how you set up your little getup?
Yes. So for us, I start setting up everything as I'm speaking with the patient, as I'm getting their blood pressure, putting their information into the system. Just how are you? I just keep moving about and getting myself ready. So it's really not wasting any time in the exam, because that's a big question of we don't have enough time as it is. How much time does this take? Really is minimal. I think it's just making sure that you put together your process and how, just like any other echo, you might do things slightly different than another sonographer. But all we do is we use a sphygmomanometer, oxygen tubing, a dispensing connector, a filter, and a syringe. So we use oxygen tubing. We use whatever comes right out of the package, no cutting, nothing. We just take it out of the package, we connect it to the manometer, and then the other side, we start connecting to the dispensing connector. So the little green piece goes into the oxygen tubing. This piece is mainly just to connect the filter, because there was no way to connect the filter. This little filter now comes from a respiratory kit, and we just take this little piece off of the tubing, and it's a carbon filter that we connect now to this little dispensing the fluid connector. So you can see the pieces there. And then we take the syringe, we take the little plunger out and connect it to the filter. There's so many different ways to do it. It's just a matter of what your system uses and what you're allowed to do. Okay. Then we have the patient blow into the syringe, and then that travels through the oxygen tubing, and then they look at the manometer and they hold it to 40. Not every patient can get to 40. So whatever they can get to, we document, and it doesn't always have to be 40. 40 was what was in the literature when we started doing it. So that's what our goal is. But we get some patients to 10, some patients to 20, and it still gives us enough of that reproducible effort that we are able to get the data that we need.
So you document how high you were able to get them to?
So goal-directed Valsalva 10, 40. And then definitely in the reporting, we should make sure that not only for the physician, but for the next sonographer that comes along to realize that, 85-year-old woman is unable to blow into the syringe up to the 40. So it really works well. I would say more than 90% of the time. Most of the patients very easily can blow into the tubing. We instruct them that don't take a breath in, just blow straight out as if you were blowing up a balloon. and try to reach 40 and hold it there for 8 to 10 seconds. Some patients, you need to do 10 seconds, some a little bit longer. It all depends on each patient individually, but it really does pull those gradients out well. And again, the biggest thing is reproducible, and we know how much effort is being put forth, as we do not know that with the instructed Valsalva. And patients tend to do some crazy things when we ask them to do that. And some of it, I think, comes from the miscommunication of how we describe it. So
Yeah.
we don't all instruct the patient the same way. And we'll hear squeeze your belly, act as if you're having a bowel movement, act as if you're giving birth. Well, not everybody gives birth, you know. So, but
Dr.
anyway,
Wharton's on mute. I can
that's
only
right.
imagine what he's saying. He doesn't know whether to unmute himself.
I said I'll second that.
So that's not good instructions. You're not going to get good information here. So it's so valuable. And we have had so many patients, they went to other sites, they've had their testing, even our own site, and they've had the testing done, and Valsalva's written on the screen, but we're not getting any gradients. But since they wrote Valsalva on the screen, they move on that they did do their Valsalva. And unfortunately, it hasn't helped the patients, and they go undiagnosed for quite some time. So this does seem to effectively give us the best data that we need.
Perfect. Thank you. Thank you. Okay, so I'm going to finish reviewing that original case study. Do you need to go, Dr. Wharton?
I can hang around a little longer if you'd like.
Okay, I'm just going to pull up that case study.
By
I
the way,
want to just do like a peer review as if we were looking through the eyes of IAC.
Judith, you'll save a lot of syllables if you just say Ron instead of Dr. Wharton.
That would, wouldn't it? Okay, I'm going to share my screen. We'll look at that study and see whether or not it would meet the proposed guidelines. We looked at the peristernals already, the long and short, and we would be looking for a measurement of the IVS and posterior wall. So in the study we showed earlier, only the septum was measured in long axis, not short. So we would ding that.
Well, you should measure it. You free caliper it. You do not
Yeah,
in your.
but I think they didn't in this study. Yeah, so see, then there was no measurement. They just showed short axis, but it wasn't measured.
Oh, okay.
They measured it here. And then here, this looks like they've accidentally, this looks like mitral valve apparatus. It doesn't even look like the septum. So that's actually a measurement error. So we
Right.
would screenshot that and provide feedback. What's funny is they did good missing the right trabeculation, which is usually accidentally included. What tips do you have for not including the right?
What we do is at times we'll move up a space. If you're like a little bit too low, like in a low peristernal window, it does tend to include more of the RV. So I'll advise to move up. The other thing is I will change the different chroma maps. Sometimes it's easier to see things in a color than it is to see it in black and white. So I'll utilize the chroma maps.
Some people go crazy with the chroma maps.
Yeah. I'll do maybe a sepia or just a mild, but not the purple.
The whole study or just for?
No, no.
Okay.
I go back and forth. Yeah, just to clarify.
One thing I might add, a great way, I think, to improve your accuracy of measurements is to add something like affinity in this image. The addition of an ultrasound enhancing agent really delineates these things very nicely.
Right. So Judith, if they do it, when they do it at the end, they can
Right.
measure
They can
again.
remeasure.
Yeah.
Exactly.
Right.
Yeah. Let me pull up an example real quick from a different patient. I just want to show how much contrast truly helps you visualize the endocardium better and get a true assessment of the size and thickness of the LV.
Yeah, definitely.
Okay, so now we're going to get to 8.
I think it's important, first of all, for us to have on axis not foreshortened images is the best, right? For every echo. But when you're getting your gradients and velocities, you don't always need that beautiful image. You need to be in the right line of flow. So parallel, or as Dr. Wharton said earlier, maybe you need to move your cursor over to be out of the LVOT. Maybe you need to move it into the aorta better, so you're picking up the aortic signal. So it's about the image when we're showing our 2Ds, but when we're trying to pick up our gradients, we need to move around to what is best going to give us the most appropriate signal.
Agreed.
This was one of the things I wanted to point out. I see labs do this a lot. They move the baseline all the way to the top or all the way to the bottom, which I think is a bad practice. You need to be able to see a little bit above or below whatever you're looking at.
Right.
Agreed.
This is just dizzying to me.
Yeah.
Yeah, exactly. What is happening?
I think that because there's so much confusion between MR and LVOT gradients, and because you are looking to see how long is my flow and is it going right up to the mitral valve, that this just doesn't help.
No.
Right. Yeah,
No.
they should always show above and below baseline, correct?
Right. I mean, that looks like LVOT just because it's 2D guided and you're not anywhere near the left atrium. And the velocity is certainly consistent with a high-grade LVOT obstruction. That would be too low for MR unless you were very offhand.
Okay, let me just see what we're going to be paying attention to based on the peer review form.
Yeah.
Okay, we're going to be looking at the gradients of LVOT at rest and with Valsalva. But for now, they have for color flow and for spectral Doppler. So I know when we talked earlier, Margaret, you guys do Valsalva with color and then Valsalva with Doppler, correct?
We do. And we were just doing it looking to see if we could show the SAM more clearly when we added those Valsalvas, so just to get the sonographer and ourselves in tune to looking for that SAM. If you put your color on and then you locate your obstruction through pulse wave and color flow, then you know where to chase it and you know where to put your continuous wave to show what the severity is. But when we're out trying to help people, we're hearing they just pulse up and down and Valsalva up and down, and they never use continuous wave. I think it's just in trying to become in tune to where is it turbulent and what is happening and when.
So let's see. I wanted to show the Doppler of the Valsalva. I was talking with Ron, and we were saying that some labs are having a hard time when the velocity speed is slowed down so that you can get as many Valsalvas as possible on the screen, that it's so skinny.
You can't
that
tell.
they're having a hard time like understanding what they're looking at.
Right. So we don't typically do that.
We do slow it, but you don't have to have it on minimum where it looks like just pencil lines. But we'll slow it. And we also will do that because we move back and forth from the MR to the LVOT. So we're showing you this is the MR, and now look, here's the LVOT, and it's on the same screen. So that's some of the reason that we've changed our sweep speed. But they don't need to make it so that they're showing so many that you can't even decipher what it is.
So do you do it at both speeds?
I do all of my measuring and Dopplers at like the biggest I can, 100, but showing more than one, of course. But yeah, we don't keep it down to a minimum speed. I move back and forth. I think sonographers have to really think and try to make sure they're showing what the physician needs to see for the diagnosis of our patients.
Right. And also at this sweep speed, you may appreciate the APC even less.
Right. Oh yeah, definitely. That's a good point.
What is your point? Sorry,
well, if you see that APC, if you don't look at the EKG, you can't see that there's an APC there.
Patients with HCM will have extrasystoles. Right? They'll have APCs. They'll definitely have PVCs, most of them, a lot of them. And you always want to make sure that what you're measuring is at the regular hour interval.
The other thing is sonographers should really show where they're taking their sample from, whether it's a full-on image or whether you change the layout on your screen so you can show your picture and where your cursor is, maybe on the left side, and then on the right side you can show your Doppler tracings. But it's really difficult for the physicians to see where you're sampling from in an image like this.
Yeah.
Any last words of wisdom for those that think they've never seen HCM before?
For the sonographers, I think that we need to understand they don't only show up at an HCM center. They show up at all of our facilities. So we need to know how to move forward when we see the HCM criteria, the thickened walls, the possible SAM, the turbulence, and the different patterns of hypertrophy. But I think that we just have to stay diligent in our scanning and always on top of the new data and all of the new guidelines that we're seeing here.
Dr. Wharton, just nodding.
Yeah. Yeah. I mean, agree with all of the above. It's pattern recognition. And that's what they really have to get used to. Okay. Eventually they'll see enough of these that they will be able to look at it and know when to chase it,
What were the numbers that you said when we had talked about the prevalence of HCM?
So, they used to teach that it was as low as 1 in 500, but it's probably closer to somewhere between 1 in 250 to 1 in 300. It's far more prevalent than people realize. That's, of course, not just obstructive, that's non-obstructive as well. And I wouldn't be surprised if when the dust settles that the amount of obstructive and non-obstructive is closer to 1 to 1. They used to teach that it was more like a 2 to 1, but we're seeing a ton of non-obstructive referrals as well. If you compare it to the number of patients that actually get billed under the HCM CPT codes, you come to the conclusion that somewhere about 70 to 75% of the patients that have this condition are still lying under the radar. And the HCMA has data that shows that the average time between when a patient first experiences symptoms and is diagnosed can be somewhere between 3 and 5 years, simply because the symptoms are not unique to HCM, so that's why it hides in plain sight for such extended periods.
So that when you told me those numbers, it made me laugh when so many sonographers say, I've never seen this, because it's like,
right.
You didn't know you were seeing it.
Right, exactly. Well, I had shared this with Judith before you came on, Margaret. But the very first patient who ever got a prescription for mavacamten outside of a clinical trial, which was my prescription, was a patient who had been managed by an outside cardiologist for over a decade for a combination of quote unquote aortic stenosis plus mitral valve prolapse, of which she had neither.
Wow.
And it was only when she got referred for a TAVR to the hospital did a different cardiologist look at her echo and quickly realized that she was in the wrong place. So on one hand, she had suffered for more than a decade. On the other hand, by the time she was actually diagnosed, mavacamten was on the market and she was spared a sternotomy.
Well, that's great.
And she's doing very well on MAVA. So
That's awesome.
Yeah.
Yeah.
All right. Well, thank you both so much. And
Pleasure.
hopefully we'll do more webinars together in the future. So in closing, just big picture here, we discussed how many people are undiagnosed with HCM. So although tonight we covered different technical skills, Valsalva, Doppler, HCM diagnosis should not depend on which sonographer on any given day performs an exam and which physician on any given day reads the exam. Excellence in echo is so much greater than us individually. What's important becomes a systematic change that is needed. In smaller labs, it happens more easily. There's less people, it's easier to all get on the same page. But in larger organizations, it needs to be intentional, defined, structured. So that's the real opportunity ahead of all of us. Not just improving measurement techniques, but making it standardized and consistent across your organization. So as we close out tonight, I just want to thank you all and remind you how much your work matters professionally, clinically, and organizationally. Thank you so much. See you again soon. Katie, I'm handing it back to you.
I'd like to extend a sincere thank you to our guest speakers, Dr. Ronald Wharton and Margaret Kurnides, for sharing their expertise and clinical insights with us today. And thank you all for joining us. As a reminder, whether you're watching this live session or on demand, our chat box remains open and monitored. Please continue to submit your questions. We either respond directly or incorporate them into future educational programs. If you would like to stay connected and be notified about upcoming webinars, new resources, and future educational offerings, please visit our website and sign up for our newsletter. For specific follow-up questions related to today's topic, you may email us directly at hcm@cardioserv.net. We truly appreciate your time and commitment to advancing excellence in echocardiography. Have a wonderful day.